Hi everyone, welcome to another in the foundation series of the ultimate job guide to being an F1, being an SHO. Today we're covering paediatrics with Dr. Natalie Hamer. Thank you so much for joining us. So a bit more about Natalie. Where's the next slide for me? Thanks. So she's currently an ST1 in paediatrics, so plenty of knowledge. She did F1 and F2 in Liverpool and then worked as a teaching fellow at the University of Lancashire with an F2 job in general peds and peds at ED, and obviously specialty jobs in general paediatrics in NICU. So we're really lucky to have her. Thank you so much for doing this talk for us. So a bit more about Medics&Me. So can you do the next slide for me, please? Thanks. We're a nationwide charity, and so we aim to guide both aspiring medics, current medical students, and people once they've graduated with their careers. So we're obviously running this Foundation Job Guide series, and they'll all be up on the YouTube as well. We run blogs about what it is to be a medical student. We have specialty application talks. We also do in-person mentoring for aspiring medics, and we'd love it if you guys came along if you're interested and did some in-person mentoring. We also run plenty of QIs and audits, which as an F1 you have to do. So getting that experience is really relevant. And if you're interested, feel free to just contact us on any of our social medias, which are Medics&Me, across basically all platforms. And on that note, take it away, Natalie.
Awesome. Thank you so much for having me. That's a nice little introduction to who I am and what I do. Hopefully I've got enough peds experience to give you the best kind of top tips for smashing your peds rotations. So what we're going to go through this evening, I'll tell you a little about what it's like to be an F1 or an SHO on peds. We'll go through a little bit of history taking and clerking and what some of the key points are for paediatrics, because there's a lot of things in there that you probably wouldn't think about in adults, but are really important when doing histories for peds. I'll give you a whistle-stop tour of some of the common peds presentations that you'll come across during your peds rotations and kind of key top tips for managing those. We'll go through what your typical jobs list might look like on peds. And then also go through some of the learning opportunities and kind of portfolio opportunities that will be available for you whilst doing your peds job. And finally, I'll just give you some of my generic top tips for surviving paediatrics. If you've got any questions at any point, please do jump in. If you're confident enough to turn your mic off and ask, you can. If you want to type it in the chat, that is okay too. And I'll try and clarify anything that's not clear or answer your questions as we go. So without further ado, let's start with actually being an F1 or SHO on paediatrics. So your kind of experience for this is going to be very hospital specific. So in some of our district general hospitals, for example, you might have a smaller peds department. You might only have general paediatrics, and any of the specialty things might get shipped out to tertiary hospitals. You may or may not have access to neonates, so that's kind of looking after our babies in their first days to weeks of life. In some hospitals, general peds and neonates are kind of smushed together, and you'll do a bit of both. In other hospitals, you might find that general paediatrics is its own hospital or department, and there is a separate hospital or department for neonates. So that's what it was like for me at Alderhay, because Liverpool have got a women's hospital. All of the neonates was done there, and I didn't really get much neonates experience. And finally, kind of what specialties you can come across. So again, when I was at Alderhay as a massive tertiary hospital, I saw all of the specialties. There was cardio, resp, peds surgery, neurology, etc. Whereas at the hospital I'm at the minute in Bradford, we don't have any peds specialties really. We only have general peds, so our specialties would get sent over to Leeds. Apologies if you can hear my dog's tail wagging in the background. She is asleep and clearly having fun in her dreams. So the next kind of key thing for peds is it's usually supernumerary and it's quite senior led. So it's kind of really great in terms of learning. Lots of people might think that that's not a positive. And I know lots of people have said they've kind of felt like a medical student whilst on their peds rotations, because they've, not had as much support as such. They've not had as much kind of freedom to go and do things independently. But actually, I learned so much because there were so many other registrars and SHOs around. If you want to go and see a lumbar puncture, for example, you're not tied to doing a million jobs. You don't have a jobs list longer than your arm. You have the time to go and do that, and there's lots of people around to learn from. So I'd definitely say that's a positive. In terms of a typical day on peds, again, this is going to change depending on your hospital and how it runs, but generally you'll start the day with a handover. This is probably more comprehensive than you'll find on other specialties. But usually the night team will run through kind of all the children on the unit, and any changes that have happened with their care overnight. Once that's done, you'll start ward round. In some places, this might be a big grand round and you might all travel around together. In other places, it will be split. So when I was at Alderhay, because this is such a massive hospital with a huge general peds department, we actually had 5 consultant teams that went round every day, and did different aspects of the ward round. Whereas when I was at Bradford, we had a smaller team, a smaller ward. So it was one consultant overseeing the ward round, but sometimes we would split down and one of the regis might see a few patients, the consultant might see a few patients. As an F1 or F2, you wouldn't really be seeing patients on the ward round on your own, certainly not in the first few weeks or months. You'll usually accompany the consultant going round or the registrar. And your job will normally be to kind of make the ward round notes, to keep track of a jobs list, so making a little list of all the patients you've seen, kind of looking at blood results or other investigations, pulling them up during the ward round for the consultant. Once you finish your ward round, then it's time to kind of look at jobs. Again, this is done differently in different places. I've worked some places where kind of I'm responsible for the jobs for the patients I've seen. Whereas in other departments I've worked in, we've kind of all come back together, made a master jobs list, and then kind of divided and conquered as a team. The one thing I'd kind of bear in mind is as an F1 or F2, there'll be certain jobs that you can do and certain jobs that you can't. Or there might be some jobs that you need assistance for. So writing discharge letters and TTOs, you can probably do that by yourself. But kind of cannulating a one-day-old baby, you might need some help and support. That might be something for the registrar to do rather than you. So kind of think about which jobs you can tackle on your own and where you might need support, might need to be support. Because often in peds we'll do things in pairs. Things like cannulas, for example, children are very wiggly. You might not be the one putting it in, but it is super important to kind of have someone helping you to hold or to keep the child settled while we do things like that. Hopefully at some point in there you'll have time for some lunch. It's really important that you get your breaks in any job, but especially peds, because you need to be bright and shiny and switched on. So make sure you get enough time and breaks for you. In the afternoon, when you come back, you'll probably still be tracking through some jobs. Most of the places I've worked, we've done an afternoon handback or board round. This is probably different to a lot of the other specialties you might have worked in, where kind of the consultants do the ward round in the morning and go home. Because we are so senior led in peds, often the consultant's around pretty much all day. So we'll often do kind of a quick run through all the patients in the afternoon so that we can raise any queries to the consultant. If we've had results that have come back, we can kind of look through them together and action them. And also if the consultants have got any updates from kind of meetings and things they've been at, they can hand that back to the team. So some of the places I've worked, we have 4 or 5 kind of handovers a day, especially on like the intensive care unit, for example. We have maybe 4 mini ward rounds a day. So you'll kind of get to know your patients inside out, which is great. And then finally, when your day team go home, they'll usually do either a formal or informal handover to the people that are staying on for the long day. Kind of as part of your long day, you'll be getting through any jobs that have been handed over from the day. You might have patients to review that are acutely unwell, or sometimes patients that have been newly admitted since the morning. And then we'll have another handback when the night team kind of hand over, when the night team take back over. The last little kind of added caveat when you're on peds is you might have some time on the peds assessment unit. This will be called different things in different places. It might be PAU, it might be a children's decision area, it might be children's assessment area. Basically, it's kind of a hybrid between A&E and the ward. So this is a place where kind of patients who aren't in an acute emergency that needs like A&E resus kind of care, but you know are unwell enough that are probably going to need assessment to the ward. So in some places, these might be children that have been seen by the GP and the GP thinks they need admission, so they can be referred directly to the assessment unit. And if you're working on the assessment unit, you will generally be clerking patients, taking kind of a full history and exam. In some cases, you might start initial management at that point if it's appropriate. Obviously, as an F1 or F2, you might not quite feel comfortable with that, especially in the first couple of weeks. But say, for example, I've got an asthmatic child who comes in and I do their assessment, their initial clerking, and they're very wheezy. It'd be completely appropriate for me to prescribe them a salbutamol nebulizer, for example. That would be okay. The really nice thing with PAU is that kind of everyone you see will also be overseen by a senior. You won't ever be the only person seeing and discharging patients kind of in these semi-acute settings. But you get to talk through the case either with the reg or consultant that's on PAU. So this is a really great opportunity for you to do an exam, think of what your differential diagnoses are, think of what your initial management would be, and then run it by a senior. And you usually get really great feedback from this. You kind of learn lots of things that maybe you missed or you didn't ask that you should have asked when the consultant goes, well, how much are they feeding? And you're like, oh, but I didn't ask. So you learn lots of really good bits from that. And it's also a really great time to update your portfolio. You'll have already seen the patient, you'll have already taken history and exam and already discussed it with a reg. So when you've done that, just add a sneaky, do you mind if I write this up for my portfolio? Could I send you this for my portfolio? Because it's not really any more work for them if they've already discussed the case with you. And often they will offer, most of the time it's the regs or consultants that have said to me, oh, do you want to write that up and send it me? So definitely take advantage of that when you're on the assessment unit. I guess that brings us on nicely to kind of history taking and clerking on peds. Some of these are kind of general tips for history taking and some are more specific. But as always, kind of introduce yourself in your role. I would hope you do this anyway whenever you see anyone, but it's especially important in peds. Parents and caretakers are, understandably protective of their little ones and they want to know who they're seeing and what you know and what your job is. So I have a kind of a general spiel. I'll always walk in and be like, hi, I'm Natalie. I'm one of the children's doctors who'll be looking after you today. We generally tend to use first names on peds rather than kind of Dr. Hamer. I'm pretty much Natalie to parents and children, and even to my colleagues. It kind of removes one of those barriers for you, which is important on paediatrics. The next really important thing is clarify who is in the room with you. Do not assume that the, nice woman and man with this child is mum and dad. You'll end up in a really sticky situation if you kind of guess that it's grandma and actually it's mum, or you assume it's a sibling and it's a parent. So just always ask kind of who is with them, clarify what their relationship is to the child. And I usually try and get names as well. And the next kind of point is always try to include and engage the child themselves. I cannot overestimate how important rapport is in peds. Even if you think the child is too young to kind of give you a history, I will always direct my questions at them first. One, it's really important that children feel like partners in their healthcare, and it's really important that they feel like they can trust you and talk to you. And it's just good general practice all round. So that might be when you walk in, what's your name? Or who have you brought with you today? It also kind of gives you a chance to gauge how much the child is or isn't willing to kind of talk to you. Some children will have absolutely no problem chatting your ear off and telling you their name and telling you exactly who they've brought and why they're here. And some children will hide away in mum's chest and not say anything, which is also fine. But if you give them the chance to speak, then you've kind of directed the question to them. And if mum or dad or granddad or carer is the one who answers, that's absolutely fine. I'd also have some really good little icebreakers in your pocket for when you're dealing with children. If you can find something to relate to them with, if they've got a Disney character on their t-shirt, or they're on their Switch playing a game, or they've brought a book in with them, if you can kind of link to that to kind of build a bit of rapport with them, that'll make such a difference. So whether that's, oh my God, is that Lightning McQueen on your shoes? That's so cool. I love Lightning McQueen. Who's your favorite Cars character? You might feel a bit silly and a bit embarrassed, but honestly, kids love it, parents love it. And it just makes everything from history taking to examining so much easier. And it's another thing to think about when you're examining as well. Do similar. So it can be really scary for kids. You're putting a temperature probe in their ear or listening to their chest. They can find it really quite intimidating. So if you can do something to make that easier. So, oh, can I have a listen to your tummy? I'm going to try and see if I can hear what you had for breakfast. Is that toast? No. Cereal? No. Sausages. Like, it is ridiculous, but if you can make it a game and make it fun, you'll have such a better time. Or if they've brought a teddy with them, can you take Teddy's temperature first? Can you take mum or dad's temperature first, just to show them that, you know, it's not intimidating and it's fun. Then I guess we should talk a little bit about actual history taking itself. So you're going to use the same structure that you use for all of your histories. You know, you're going to do history presenting complaint, past medical history, medications history, family history. But it's really important in peds that that history is detailed, specifically when you're getting kind of the symptoms of events, especially if you're getting some history from the child, some history from grandma, some history from dad. It can be really hard to kind of weave that all together and work out what's been going on. So make sure that you clarify the sequence of events. And this is really important in peds, especially for like conditions like bronchiolitis, for example. It's a really common condition we see in paediatrics, and it generally tends to get worse round about day 3 to 5. So if someone has brought in a baby and I think they've got bronchiolitis, they've got breathing difficulty, they've been a bit snotty, and they tell me we're at day 2, and I was on the fence about whether or not to send this family home or keep them in. If I know they're on day 2, I'm thinking in my head, okay, this is likely to get worse on day 3, day 4. So actually, maybe I should keep them in. Whereas if they tell me they're day 4, I'm like, oh, we should already be at the peak. I'd feel a little bit more confident sending them home. So yeah, make sure you've got a good kind of overview of what has happened. In terms of your history taking itself, there's some extra history questions that you need to think about in peds. So the mnemonics such as binds and heads can be helpful. Obviously, you need to take these with a pinch of salt. So when we're thinking about a binds history, it's, you know, we're thinking about the child's birth history, immunizations, nutrition. If I'm seeing a 15-year-old with a headache, their birth history is probably less relevant. I probably don't need to ask about that. But if I'm seeing a 3-month-old with a temperature, it's probably really important to know, were they premature? Were they on time? Were they unwell when they were born? Were there any risk factors for infection? So did mum's waters go really early? Was there anything concerning on our antenatal scans, etc.? Immunizations, we all forget to ask immunizations, but it's really important. Are they up to date for that child's age? So if they're a baby, have they had their 8-week IMS? If they're older, have they had all of their immunization schedules? Because that helps change your differentials list if they have or they haven't. Then we want to think about nutrition. You probably don't overly ask this to your adult patients, but I want a detailed summary of kind of what this child or baby has been taking. So if they are a baby, how much are they feeding? How often are they feeding? Are they taking artificial formula or are they breastfeeding? Have we started weaning yet? So is the child on any solids? And that's really important to know for quite a lot of conditions in peds. Some of the other things you might want to think about development. So does the child hit all of their developmental milestones? Do parents, grandparents, carers have any concerns about how the child's developing? And the last thing you're going to do, probably more detailed than what you would do in adults, is a social history. So I want to know who else lives at home. Is anyone else at home unwell? Does this family have any social care involvement? And if kind of child hasn't come in with parents, or they're adopted or a foster child, you want to think about things like who actually has parental responsibility for this child. So there's lots of extra things to think about in peds. And I guarantee for your first few histories, you will forget some of these. And it's only when you go and present your history to the reg and they go, what's baby feeding? How many wet nappies has baby had? And you go, oh, oops. And then you will start remembering them. What I did for my first couple of weeks as a peds SHO is I had a little piece of paper, and on that piece of paper I had kind of my binds and my heads. So heads is something we use in our our kind of adolescent teenage children, and it's thinking about their home life, their education, their kind of activities and hobbies, whether there's any drugs, alcohol or smoking use, and whether they're kind of in any relationships, are they sexually active, how's their mental health, if they thought about self-harm, those kind of things. But yeah, I would take a little piece of paper and I would put those on it, so that when I'd done my normal history that I felt like I had down, I could then be reminded to ask those questions. Okay, so we've talked a little bit about what you can expect as peds F1. We've talked a little bit about some kind of top tips for history taking and clerking in peds. The next thing to talk about is some of the common peds presentations that you might see whilst you're on your peds rotations, especially if you do a peds rotation over winter. So bronchiolitis, I mentioned briefly before, that is a really common one. So this is a viral infection. It's normally caused by RSV, but can be caused by lots of other viruses too. And the mainstay of care for bronchiolitis is supportive care, really. There aren't any specific medicines that we give, apart from a bit of oxygen if required. But the main things to think about when looking after a baby with bronchiolitis is feeding for a start. How much are they feeding, and are they working really hard when they're feeding? Their fluid status. So you're going to examine them and make sure they don't look really dehydrated. But the quickest way to find out someone's fluid status in peds is seeing, are they having wet nappies and how many wet nappies they're having. If a parent tells me they've not had a wet nappy today and we're at 3 PM, I'd be more concerned about this baby. And the last thing you're going to look at is their SATs and their work of breathing. So they're the things that are going to decide whether this baby is well enough to go home with a bit of kind of supportive care and safety netting, or whether I think this baby needs admitting. So if they're not feeding well, if they're dehydrated, or they're working really hard and needing oxygen, they're the things that are going to make me want to keep this baby in. And they're the things that I'm going to be assessing while I'm looking after them on the ward. So then we've got viral-induced wheeze on a similar vein. So again, it's a viral infection. This is our slightly older children, usually over the age of 2. We do have kind of an awkward little overlap between like 15 months to 2+ years, where they could act more like a bronchiolitis, they could act more like a viral wheeze, and then it gets a little bit tricky. But generally our bronchs are our babies kind of under 2, under 18 months, and our wheezes are our over 2s. But in our viral-induced wheezes, we do actually have a few more things in our arsenal. So we do get some bronchospasm in viral-induced wheeze. So we can use bronchodilators. We can use things like salbutamol nebs, which we wouldn't use for a bronch. And also we have oxygen. So when you're looking after these children kind of in hospital, one of the main things we want to think about is whether we can stretch their salbutamol. So usually we'll start, depending on your hospital and your kind of protocol, we might start them on having kind of a salbutamol nebulizer or inhaler every hour. We'll then do a wheeze review. So you'll go and see this child just before they're due their like inhaler or nebulizer. You'll have a listen to the chest. You'll see, are they working hard? Are their SATs okay? Do they sound wheezy? If you listen and they've got really good air entry and they don't sound wheezy and they're managing, you can then stretch that salbutamol to 2 hourly. And then you'll do the same again just before 2 hours, and see if you can stretch to 3, and then try and get to 4. Once we're at 4 hours, that's when we're happy that we can let these children go home. So you're going to be doing lots of stretch reviews, lots and lots of stretch reviews, so you'll get very happily listening to chests and listening for wheeze. The other key questions kind of for our viral wheezes are, have they managed to have a sleep without oxygen? So even if our children are oxygen free during the day, we often find that at night their SATs will dip and they might need a bit of oxygen. So we need to make sure that these children are safe to sleep at home without oxygen. And lastly, for all of our peds conditions, if you're sending anyone home, it's really important that you've safety netted. You need to tell parents what to look out for and when they need to bring their baby or child back to hospital. And personally, I always put this information on the discharge letter as well. So I will tell them verbally, and I'll also make sure it's on the discharge letter to say kind of if your baby's working really hard to breathe, if they're not having wet nappies, if they're not feeding, if they're really sleepy and lethargic or floppy, then come back and have them assessed. Then we've got our asthma exacerbations. So some of the key things in your asthma history are finding out how well or not well controlled this child's asthma is. So ways you can do that are asking what they're like when they're well. Do they have any interval symptoms? Are they wheezy at rest? Do they have a cough on a night? Those kind of questions. You might want to know about their inhaler use. So inhaler technique is really, really important. I want to know that they're doing it well, and I will usually make them show me how they use it. Do they use their spacer? Because if they've got normal kind of pump inhalers, they should all be using a spacer. And I want to know how often they're picking it up. If they're going every week to refill their prescription, that tells me that their asthma is not very well controlled. And another really helpful question can be how many kind of hospital admissions have they had with their asthma. One of the things I'd recommend in terms of asthma management from a maintenance point of view is you may or may not be aware, but I say recently, last kind of November, the guidelines for asthma changed. So I'm sure most of you will be familiar with kind of the blue and brown preventer and reliever inhalers. But actually, the NICE guidelines now suggest that most children should be on MART therapy. So that's M-A-R-T. And it's basically a combined inhaler that's got a steroid and a kind of beta agonist, a salbutamol-esque medicine that they use as both a preventer and a reliever. So if you're not familiar with that, have a quick look at the NICE guidelines when you get a chance, because that's something that you'll start seeing more and more of as these children come into hospital. And in terms of assessment of these children, the kind of main spot diagnosis red flag things are, can they speak in full sentences? Because if they can't, I'm worried. Are they working really hard with their breathing and maintaining their SATs? And the scary one is, are they tiring? So if you listen to a child with asthma and they sound wheezy everywhere, and then you come back and listen a little bit later and you can't really hear anything, you might not hear much wheeze, they've got very little air entry, you're not getting good breath sounds, that is a really bad sign in asthma. It's that the airways are so tight, they're so constricted that they're just not getting enough air in to even create a wheeze. So if you ever hear someone with a quiet chest in one of your asthmatic children, go and get a senior, go and get someone else to review and have a look, because that's a scary sign. Some of the other common things you might see on peds is diarrhea and vomiting. We get absolutely loads of DMV on peds. A lot of them can be managed at home. Again, you're going to decide this by doing a bit of a fluid review, seeing how hydrated or dehydrated they are. And if you're on the peds assessment unit, you'll see lots of children having what we call a fluid challenge. We also use fluid challenges for children with sore throats. And we're basically seeing, can this child tolerate oral fluids? So normally you'll give parents a piece of paper and you ask them to write down whatever they manage to take. In our diarrhea and vomiting, you might give them some anti-sickness medicine first and then see what they can keep down. For our children with sore throats, you might give them a throat spray, for example, like Diflam, and then see if after having that they manage to tolerate some fluids. If they do, we can usually send them home with some advice. But if we're not managing to keep fluids in, then that's when we need to think about admitting them. Other things that you might want to think about, especially for diarrhea and vomiting, is checking their UNEs. We don't do bloods as often in children as we do in adults, but if I've got a child that's profusely vomiting or has really bad diarrhea, you probably want to make sure that their electrolytes are okay. You'll also get a lot of abdo pain in peds, and it can be caused by an absolute plethora of things. Some key things for your examination is it distractible? So a lot of time they might wince when you go to press their tummy or not really want you to. A nice little sneaky way to examine abdominal pain I've found in kids is I'll use the stethoscope and say, oh, I'm just going to have a little listen to your tummy. And then I will press down on the stomach with the stethoscope. So I'll put a little pressure on. Because what you might find is actually you can press down with the stethoscope and they're kind of anticipating and jumping rather than jumping from pain. And if you distract them and you talk about something else or you pretend to be listening to their bowel sounds, sometimes you can get a more accurate assessment of how much pain they're in with their tummy. You're going to look for if they're guarding and they don't want you anywhere near. Another silly thing that I've only ever done in peds and never in adults is ask if I've got a little one with tummy pain, I'll ask them if they can jump up and down. If they can, again, that's a really reassuring sign. Whereas if they've got something really inflamed in that tummy and their kind of peritoneum is inflamed or they're guarding, they won't jump. They won't want to jump. It'll hurt too much. They'll be like, absolutely not. So it's another one of those fun ped-specific exam techniques. And the other thing we do is use quite a lot of scoring systems in peds. So PARC is one in particular that we use for looking for appendicitis. And it basically tells you kind of how likely or unlikely it is that this child has got appendicitis from their symptoms and some of their blood results and things like that. So that's something that you might not have come across in adults before. And my last kind of peds condition that you will see loads is jaundice. You'll get lots of babies that come in with newborn jaundice. My best top tips would be, if you've not seen them before, is familiarise yourselves with bilirubin charts. So the way we decide whether or not they need treatment is we will check their bilirubin level and we plot it on a chart. Some places will use electronic charts, which makes it really easy. You just put the number in and it plots it for you. A lot of places will use paper charts and you need to be able to plot it yourself. So when you're doing that, you need to know the date and time the baby was born. That's really important because then you can be able to plot it, and you need to know what time the test was taken. So if you're not familiar with that, have a look at it, because it can be it's really easy, but the first times you see it, it can be a little bit confusing. And then key things for jaundice histories are kind of, again, are they feeding? So jaundice can make babies really sleepy, which can put them off their feed. So we want to make sure that they are getting enough in. And then you want to think about your red flags. So most of the time, jaundice is completely harmless, and it's just baby's liver is a bit immature and it needs to get used to kind of filtering bilirubin from the blood. But kind of your red flags in a jaundice history would be if the baby was jaundiced in the first 24 hours of life, or if there's any signs of infection. So sometimes when babies are unwell and have kind of sepsis and infection, they can get jaundice. So that is a whistle-stop tour of some of the most common peds presentations. I see each of these every day, at least. You can kind of go into detail about these for days, but that's some of my best kind of short top tips. Then if we talk about typical jobs that you might do whilst you're on peds, we've already briefly mentioned wheeze reviews. These can take up a lot of the day, especially over winter when you've got kind of 10 plus children with viral-induced wheezing. But it's really important that these are on time, because that's what's going to tell you whether or not you can stretch this child's medicine. And if you miss it, that's them staying in at least another hour, and that can add up. On your jobs list, you're probably going to have things like bloods and cannulas. Now, as an F1 or F2 on peds, you won't necessarily be expected to do cannulas. I don't think my job ever expected me to be able to do that. You might be asked to help. If you've got a more senior SHO or a registrar, for example, you might be asked to help hold the child to do a cannula. And honestly, I think that's harder than actually putting the cannula in. Having someone keeping them still makes it so much easier. So you'll probably go along to do that. If you're super keen and you know you want to do peds, you can learn to do cannulas. I've helped many a F1 or F2 during my time, kind of talked them through how to do it and helped. So that is something that you can do if you want, but it's not expected. In terms of blood tests on peds, what the majority of our bloods are done through a heel prick or a finger prick. So rather than doing kind of venous stabs, which we might do for our older children, and again, you might be able to do that for your kind of older teens. But for most of our babies and toddlers, we just use a little finger pricker like you'd do if you were checking a blood glucose. We do a little prick and then we fill up tiny, tiny peds tubes that you can probably see down here. So a really good way you can make yourself useful is kind of learn to do that early, because it really doesn't take any skill. It's more just practice. And that's a way that you can really help out on the ward. You'll probably do quite a lot of fluid reviews. So having a look, do they look dehydrated? How much fluids have they had? If they're not drinking a lot, have we optimized everything we can optimize? So have we given them Diflam if they've got a sore throat? Have they had some paracetamol to help with the pain? Have we given anti-sickness if they're vomiting? And also thinking about those bits we mentioned earlier. So are they weeing? Are they passing wet nappies? One of the things I initially found quite surprising was on peds, we actually do quite a lot of lumbar punctures. So in most of our newborn babies, if they have a temperature or they have a high CRP, we'll often do a lumbar puncture to rule out meningitis. I'm not suggesting by any means as an F1, I'm expecting to be throwing LPs out left, right, and centre. But again, if you're keen and you want to get involved, it can be a really good way to experience the procedure. So as you can see in this little photo here, when we're doing babies, we normally have someone holding the baby. So we fold them in half, almost like a croissant is the best way I can describe it, to make their spaces as big as possible. So we normally need someone to hold baby, and we also need someone to try and catch the CSF as it comes out of the lumbar puncture. So the person putting the needle in will be holding the needle still, and they'll be sterile, so they can't touch the bottles. So you'll normally need someone to hold the bottles and come and catch the drops as they drip out of the back of the lumbar puncture. So that's certainly something that might be on your list. The more common things that you'll be used to doing everywhere are obviously kind of discharge letters and TTOs for patients going home. We try and make our discharge letters quite comprehensive in peds because it's important, especially if they come back again, that we know what's gone on. People can find prescribing in peds really daunting because it's different than prescribing in adults. It's not just kind of a one dose fits all. It changes based on baby's age or the child's age. There's also a lot more consideration of the child's weight in pediatrics because it can make a big difference. So some drugs will be prescribed off weight rather than age. My best advice would be, if it's the first time you're prescribing something and you're not sure, just get someone to check it. Because our children and babies are so little, what might have only been a small mistake and have not made much of a difference in an adult will make a big difference in peds. So just get someone to look it over. You might be asked to update families and talk to families about what is going on. So my best tip here would be make sure that you know the information before you go and speak to families and kind of know what the plan is and know what's going on. And if you don't, be honest about that and just say, I'm not quite sure, but I will find out for you and get back to you. The families on peds can be quite intense, and you can feel like you're being grilled and that you don't have all the information, especially as an F1 or F2. I didn't know enough to be able to answer their questions well, and that felt quite stressful for me. But I think parents will respect it more if you just say that. So I'm not sure, but I will find out. And last little bit will be kind of examining children and assessing children throughout the day. So you might have a child that's become more unwell. You might have a new admission. They might go, this child's now got a red ear. Can you have a look? So kind of when you're examining in peds, again, keep it playful, make it as fun as possible. Try not to make it daunting. And one of my best tips would be use parents. So if I need to look in a child's ear, I will get mum or dad to kind of hold them and bear hug them. Because one, that's better for the child than being restrained by one of us. It kind of gets parents involved and give them something to do and makes it much more likely that you'll be successful. If it's the first time you've done something, if you've never looked in a child's ear before, if you've never looked in their eyes, then, or you've got like a rash review and you don't know what you're doing, ask someone to go with you. That is the great thing about peds. There will always be extra people around. There'll be an SHO, there'll be a clinical fellow. You might have advanced nurse practitioners that have been doing this for 20, 30 years, registrars. Just get someone with you. Once you've done it with someone a few times, you'll be confident enough that you won't need it, but take advantage of the extra bodies while you're on peds. Okay, that brings us on to kind of opportunities and doing your portfolio in peds, because there's lots of things that you'll come across here that you don't really do anywhere else. So there's a lot of meetings in peds. There's a lot of MDT discussions. There's a lot of big grand rounds. And it's a really good time to take advantage of this and get on top of it for your portfolio. So you can write up that you've been to an MDT meeting and you can kind of reflect on that. It looks really good. So some of the things I've done, I've worked in departments where we've had a weekly X-ray meeting where we will sit down with the radiologists and go through some of the kind of weird, wonderful, or interesting cases that have come up over the week, and you can learn quite a lot from them. I've worked some places where we've done kind of a weekly palliative care ward round where we go round and kind of look at, it doesn't necessarily have to be end of life, it might just be complex children that have a lot of kind of symptom management, for example. So I would go round with them and you can learn quite a lot from that. One of the sadder, but you also learn quite a lot from most of the departments I've worked in, we've had kind of a monthly mortality meeting where we look at unfortunate cases where children have passed away and kind of, you know, talk about what were the red flags that this child showed, what were the big steps in care, was there anything that we could have done better, was there anything that we did really well, and again, they're usually a really good learning opportunity. And one of the big things I've found in peds is every department that I've worked in, there has been so much teaching. So on the neonatal unit at the minute, we do 15-minute fundamentals. So after handover in the morning, every week we do a quick 15-minute crash course on particular neonatal conditions. We did something similar on my general peds job. We did a weekly teaching in the morning where one of us would pick a topic and present. So it's a really good opportunity for you to present at teaching and get feedback and put it in your portfolio, which is required as part of F1, F2. But it's also a really good way for you to kind of learn and keep your knowledge up to date. So absolutely take advantage of that while you're on peds. The next big thing is QI projects. Again, something that you have to do on peds, but this will come up loads. Do some good kind of suggestions of QI projects you could do is looking at your bronchiolitis management for your babies. Are you following the current guidelines? Are these babies being assessed appropriately? You could look at asthma care bundles. Do all of the asthmatics you send home have an asthma care plan, for example? Really quick, really easy to do. You could look at the use of scoring systems for things like appendicitis or tonsillitis. Are you using them? Is it being documented in the patient's notes? You could look at information given to families. So I did an audit during this rotation where for all of our children that were admitted, I had a quick questionnaire that went to parents saying, do you understand why your child's been admitted? Do you know what medicines they're on? Is there any information you would have liked to have that we've not given you? And kind of I've then been able to use that to tick off my QI project criteria. So it's a really good place to do it on peds. One, because there's lots of people around, so you're not as kind of time pressured for jobs. And two, because we're really investing in things like QI projects and audits, so the team will absolutely love to have you on board for stuff like that. Some of the other opportunities on peds that you don't really get anywhere else is safeguarding. So you might have the opportunity to go to a child protection medical. These usually happen on the ward. They'll be consultant or senior reg led, but we always have someone there to scribe. You might also get the opportunity to go to things like case conferences where social workers, schools, the police, and a peds representative will kind of meet up to discuss our concerns around a child. And lastly, simulation. I've done an awful lot of simulation on peds. It's a really good way for you to practice dealing with emergency situations in a safe space. Emergencies in peds can be terrifying. So if you have the opportunity to practice sim, absolutely do it. It also kind of lets you practice being a bit more independent because, as I was saying earlier, you don't get as much opportunity to do that in your peds job. And then finally, I've just got some general kind of peds top tips for you. So my first one would be have fun. In what other specialty can you go to work in fancy dress or have pockets full of stickers or prescribe a therapeutic ice pop, which absolutely we used to do at Alderhay. We had a freezer full of ice pops, and if we had children with sore throats, we would prescribe a therapeutic ice pop. So enjoy it. You get to be silly, you get to be giddy, you get to play games and examine teddies. Make the most of that opportunity. Kind of on the flip side to that, when peds is sad, it is really sad. And that is a picture of me sobbing in the doctor's office after a night shift, just to show that, we all get there. You might see some horrific things on your placement. So please speak to your friends and loved ones, speak to your colleagues. If you have the opportunity to attend kind of a hot or cold debrief after an event, absolutely do. I have found them invaluable for helping me deal with some of the things that I've seen on peds. Next, I'd say if parents or children ask you a question and you don't know the answer, be honest. Trust is everything in paediatrics, and the minute that family or child lose trust in you, you've lost the battle. So if you don't know the answer, tell them that. Try to be as informed as you can when you speak to families, but there will always be something that you've not thought about or not asked. So just bear that in mind. Make the most of your learning opportunities. Hopefully, I've emphasised that enough throughout this talk. But you have so many opportunities on peds that you don't have elsewhere. So do a QI project. Ask the reg if you can go with them while they counsel a family, or they do a wheeze review, or they do a lumbar puncture. So you get to learn that. And rapport is everything. Be silly. Kind of acknowledge and speak to children, use their names, find some common ground, and make sure that you actually treat the children like the patient and not kind of just ignore that they're sat there. And that is my whistle-stop tour of paediatrics as an F1 or SHO. I will hand back over.
Yeah, thank you so much. That was amazing. I've put in the chat the link for the form and some of the upcoming sessions. We'd really appreciate it if you filled out the feedback. And as we said, we'll send out the slides to anyone who completes it. If people have any questions, feel free to pop them in the chat and I will ask away. Alicia says, thank you so much. That was really helpful.
You are more than welcome. And if anyone thinks of any questions after the fact, my email is around. We can send it out to you. I am more than happy to kind of answer questions, whether it's about a peds job or if you decide you want to do peds and want some advice, I am around.
Doesn't seem like we've got anything on the chat, so I will end the recording. Thank you so much, guys.
Thank you, guys. Enjoy.